thank you very much for inviting me, David King, Ben Sessa, and all the rest of you guys. So I'm going to be talking about cannabis, its uses, and positive and negative effects. But also, given the kind of remit of this, of the other speakers, what they've been talking about, especially Melissa, and given what we've recently been doing with government to try and push our agenda, I thought I'd look at how drug science can actually inform drug policy, although it very rarely happens that science does inform policy, but we're trying to push it. Now clearly most of the time, at the moment people are using cannabis, it's for pleasure, and if some of you saw that TV program recently, you'll see that we have been studying pleasure with cannabis, looking at how the brain does respond differently to music, for example. So Bob Marley was right when he said the weed and music go together. The brain responds in that way. But it's for thousands of years cannabis has been used for religious and spiritual uses. You can see in ancient Egyptian carvings, can you see the cannabis plant coming out the top there? It's clearly been used in India and China for many years. And someone was telling me this photograph here is East European nuns who opt not to use the wine at Eucharist, but to use a spliff. The medical uses go back thousands of years in China and in India, but as Melissa pointed out in her talk, bizarrely, according to the UN Convention and therefore also in the UK, cannabis remains in Schedule 1. The scheduling is kind of different from the Misuse of Drugs Act. The scheduling is all about medical uses. And the UN Convention, as well as the UK itself, says that marijuana, cannabis, has no medical use. This means, obviously, enormous implications for people who like to use it, but also for research. So you can only do research with cannabis itself, which we do a lot of, under a Home Office license, but not many people have a Home Office license. We do, which is great, but it costs a lot of money, so it hampers research. And we know that cannabis is potentially a treasure chest of potential medicines. I think it's already been mentioned that cannabis has at least 70 unique ingredients that we call cannabinoids. Now, research has studied predominantly 2 of these, although we know a little bit more about things like THCV and other ones now. But basically, the main research has been for years on THC, which is stuff that makes you stoned. It also induces anxiety acutely, and it also produces psychotic-like effects, especially when taken IV, and a lot of the research in the States has been IV administration. In contrast, that's why I've put the sort of yin-yang symbol, CBD has many opposite effects. Cannabidiol is calming, it reduces anxiety, and research in Germany in a treatment trial has shown that CBD can actually reduce psychotic symptoms as well as existing antipsychotic medications. They also have contrasting effects pharmacologically on the brain. We all have a natural cannabis system in our brains that we call the endocannabinoid system. And so there are natural chemicals that mimic cannabis's effect on the 2 types of cannabis receptors in our brain. Now clearly, if we have cannabis receptors in our brain and we have natural cannabis substances, it's not there, God didn't put it there randomly. It's there because it's there for a reason. And it's really, really important. And we're now discovering what the brain's natural cannabis system is doing and how it differs in disorders like schizophrenia. And we've shown recently how people who have chronic cannabis problems, meaning that they're dependent, that actually changes the level of natural cannabis chemicals in their brain. And when they stop using cannabis, an American study recently showed, those natural cannabis compounds go back to normal. So it's only a transient effect. Very, very interesting. It's teaching us a lot about the brain. Cannabinoids have been used medically in the UK since the 1980s. This has probably been mentioned before. Pure THC is great for radiotherapy. It's great to stimulate appetite in late-stage AIDS. We've already mentioned Sativex, which has come in at Schedule 4. And at the moment, research trials of especially CBD are going on in schizophrenia, anxiety, cancer, glaucoma, obesity, addiction. In addiction, we're doing the research, epilepsy, and more. So the current trials, I'd just like to mention the epilepsy, because this is work that GW is doing. 5 trials in the States, 1 trial in Edinburgh, where children born with very appalling epileptic syndromes, Dravet syndrome being the classic, where they have multiple fits each day. And in Colorado, Charlotte Figge, who's pictured on the swing, her dad, very intelligently heard about early work with CBD. He persuaded a farmer to grow cannabis, which genetically, the seed was meant that the product was nearly all CBD. It had a very small level of THC in. And then he produced an oil from that, and Charlotte went down from like 12 to 20 fits a day to maybe 1 a week. And so the pressure now is on parents all over the world to get this stuff developed. But at the moment, it's a monopoly from GW. If you're interested in it, Charlotte has developed, her dad's developed a website, and it's called Charlotte's Web, like the children's book. Most researchers focus on cannabis harms. These are the main ones. Psychosis is very small. It's been overhyped by the press. That very, very few people, and it's only if you're vulnerable for lots of other genetic reasons and environmental reasons, that if you are vulnerable, cannabis added to that might tip you over. But a much bigger problem is addiction, where it's 9% of users will become clinically addicted. But even so, you're talking about in the same ratio, the same percentage with alcohol is 14%, so it's much less addictive than alcohol. Memory impairment is a transitory thing that everyone experiences, and respiratory problems are basically due to people smoking it with tobacco mainly. There's obviously lots of other ways you can give it. We always use a volcano vaporizer, which is much less harmful. And generally, the harms of the drug have been overhyped. This was a meeting that Dave Nutt organised with a load of us in Europe. We had representatives from virtually every European country, and we ranked the harms of drugs. And it was remarkably similar how we all agreed that, you know, compared to alcohol, which is the #1 harm to the individual and to others, you know, cannabis was way down in the ranking. But the way that politically drugs are always talked about is that alcohol and tobacco are talked about as alcohol and tobacco, not drugs. Now with cannabis, clearly it's been used medically. Queen Victoria used tincture of cannabis for all her childbirths and for her period pains. Dave Cameron, can you recognise him in the middle up there? Yeah, he got caught scoring cannabis in Slough when he was at Eton, and he was he was with 7 others, 6 of whom were actually sent down. They were expelled from Eton, he wasn't. But he was made to copy out Jordix, which are kind of chapters of Virgil in the original Latin, and he also wasn't allowed home for a month. So, you know, it's a kind of new take on the criminal justice system. Maybe we should follow that and see what happens to people. And famously, Barack Obama said, as a kid, I smoked pot. I don't think cannabis is more dangerous than alcohol. I think if he was speaking truthfully, he'd say it's a lot less dangerous than alcohol. But at the same time, we're having problems. This is the recent UK data of under 18-year-olds who are accessing specialist drug services by the primary drug. And if you look, the top curve is cannabis, which is extraordinary, isn't it, for a drug? And it's going up. It's been going up from 2005 up to 2013, whereas alcohol has kind of peaked and gone down, and other class A's don't really feature much at all. And I think our research over the last 10 or 12 years has been linking this increase to what's actually happening in the market, where from, say, 2002, you've been having a gradual increase in the percentage. This is police seizures for the first 3 points, that those, the percentage of the sample that has high THC and no CBD has been going up. And it's almost parallel to the increase in kids needing treatment, which is only a correlation, but suggests there might be something going on in terms of the mental health effects of the varieties of cannabis you can actually buy on the street. To look at this, we did a big study with 620 16 to 23-year-olds, and we got them to smoke their own cannabis. They'd used for at least a year, or some of them were controls who never used. And we tested them on 2 days, 50%. We tested them the first time when they were intoxicated with their own cannabis and as stoned as they wanted to be. And then a week later, we tested them as sober. For the other half, we tested them sober first, and then when they were stoned. And what we found, so the red bar is what the popular press calls skunk. So it's got a low CBD content, and the green bar is the more balanced one. And when they weren't intoxicated, there was no difference in the memory function between kids who were smoking, young people who were smoking high THC compounds compared to low THC. But when they were intoxicated, what we found was that, as you can see on the graph, if your cannabis had good levels of CBD, then your memory was not impaired. If it didn't have CBD in it, you had a memory loss. Yeah? So this strongly suggests that CBD actually protects your brain against the memory impairing effects of THC. The other thing that we looked at with attentional bias, there's lots of psychology research showing that as you become addicted to a substance, so especially alcohol and tobacco, if you're seeing pictures of the environment like adverts for alcohol or whatever, and you have a problem, your eyes go to those things, or the smell of going past a pub or seeing adverts for vodka or whatever is a problem for people who have a problem with alcohol. Well, similarly with cannabis, if you've developed a problem with the drug, which again is a lot less people that develop a problem with alcohol, then your eyes move towards cannabis-related things. So if you see pictures of cannabis or you smell cannabis, so increasingly, as someone develops a problem, this is what they develop. And again, we can measure that by looking at eye movements, by showing pictures or whatever of cannabis and neutral stimuli. And what we find is that if those young people's cannabis contained CBD, they didn't have this. If it had no CBD, their eyes went straight for the cannabis-related stimuli. So this again suggests that CBD counteracts the addictive qualities of THC. We looked at the 600 young people in terms of which kind of cannabis they preferred, and we had to do this rather than look at just the THC and CBD content, which we measured in their hair and in the cannabis they smoked, because they just couldn't get balanced cannabis, large numbers. I mean, it was difficult. And what we found, so these bars on each of the bottom there, the first one is if they didn't express a preference, they didn't mind which kind of cannabis they had. The second bar is if they preferred herbal or resin type cannabis. And the red bar, I've used the term skunk, which I don't like, but it's a quick and easy term. And basically, if we look at all these indices of addiction, so the number of clinical criteria for cannabis dependence in the first one, the craving for cannabis when you're not intoxicated in the second one, and the days it takes you to smoke an ounce or 3.5 grams in the third one. And on all these, we had a significant effect, so that the high THC preferers were much more likely to show dependence. And if we just treat it, we gave them interviews in terms of psychiatric diagnoses. And again, those who preferred high potency cannabis were much more likely to meet criteria for cannabis abuse. And so the red bars are yes, they did meet criteria. And in terms of cannabis dependence, a similar effect. And Marta Di at the Institute of Psychiatry, she's not done biological sampling like we have, but she's asked schizophrenic patients what they prefer to smoke or what they most often smoke. And again, she's found that smoking high potency or high THC varieties increases the rate of psychosis only in individuals who are at risk for lots of other reasons, not in your normal, general cannabis smoker. And that attracted huge amounts of publicity. But we actually find that it's not the same, it's not extreme in ordinary cannabis smokers who aren't psychotic, who aren't schizophrenic. Outside the UK, Melissa already mentioned that you have like 23 states in the USA plus the Columbia District regulate cannabis for medical use. Cannabis is available in Health Canada, in Israel, where some of the pioneering work was done on cannabis. It's around medically. And the Netherlands, we mentioned Bedrocan, where we get our supplies from as well. And Bedrocan now also supply Switzerland and Germany. And the recommended uses, we've been working with a clinic in the States to see what kinds of reasons doctors they can't prescribe it, but they can recommend it. And the main symptoms are to do with pain. And it seems to be especially good for neuropathic pain, which we're hopeless at treating in other ways. Anxiety, sleep problems, spasms in multiple sclerosis or forms of spinal cord damage. The other ones I've already mentioned, but we do see recommendations for writer's block. This clinic's in California. Writer's block's a new psychiatric diagnosis as far as I'm concerned. But what's really interesting, there's a paper out 2 weeks ago by Hassin et al., who've been collecting data on cannabis use by adolescents in 48 states in the US. And what's really reassuring is that making cannabis available medically, comparing those states where it is available medically with where it's not, the Americans have always worried about medical cannabis being diverted. At all the clinics, you're not allowed it under 21, yeah? And they were really paranoid about the adolescents getting hold of it. But this paper is a huge data set, and I think it's shown really, really well that it doesn't matter if it's medically available or not in terms of adolescents' use. So it's not being diverted onto young children. So for the UK, where we have no recognised medical use, what we've been doing, and I think Melissa was at a meeting at House of Lords last year, where we were talking about this, that at the moment, cannabis is in Schedule 1, no medical use. If it was put into Schedule 2, then drugs could be prescribed and therefore legally possessed and supplied by pharmacists and doctors, and possessed lawfully by anyone who had a prescription. And Schedule 2 already has heroin in it. Heroin is diamorphine. I mean, it's a bit similar, isn't it? Because, why should heroin be a lower schedule than cannabis? It's bizarre. So what we've done, 2 weeks ago, we submitted this report. We did a review of the scientific evidence, and we submitted that via Baroness Molly Meacher to the government. And we're now awaiting Cameron, one of his lackeys' response to, really trying to argue that it is high time now we made cannabis Schedule 2 as the first move in changing the legislation. The benefits of rescheduling are that, as Melissa said very eloquently, that it promotes human rights. If it alleviates pain and benefits their health, why should they have to go on to Eurostar to the Netherlands and get a nice Dutch doctor to prescribe and then have to smuggle it back in on the way back? Whoops. It enables patients to have cannabis with a guaranteed dose and a ratio of THC and CBD, because a lot of patients are saying it's not fair, we can't get, we don't want to grow it, but if they don't want to grow it, then they have to get it some other way, and they're not being able to access lower THC, higher CBD varieties. Reduces NHS costs. Sativex, for example, costs over £150 a week and is not available to many because of the NICE guidelines saying it's not an effective medication. Bediol from Bedrocan, which is a very nicely balanced form of cannabis, would cost £20 a week in contrast. I don't know what's happened to the graphics here. And it would promote UK research, as few researchers hold Home Office licenses, and it would also reduce the costs. Because to hold all the drugs that I hold in my labs, the security arrangements are just so expensive. And another benefit is rescheduling is that a lot of us, if you agree, think the Daily Mail has a bigger influence on drug policy in the UK than drug science. And I don't think the Daily Mail understands scheduling. They understand the Misuse of Drugs Act, but I think scheduling is outside their remit because it's a medical scenario. So hopefully they won't say too much and we can do it under the carpet. So these are the guys that I work with, so thank you very much.